Hello, everyone. Dr. Scott Sigmund. I like to describe myself as the original opioid-sparing orthopedic surgeon, healer of knees and shoulders, left and right, social media influencer, hashtag follow the fro, host of the Ortho Show podcast. We've got a lot going on, but it's a pleasure to be here. I don't know if you guys all remember. You remember back in 2019, we were actually able to go to conferences and see people. Hopefully that'll change again, but it's a great opportunity to be here virtually to be able to describe what is really, for me, one of the most important topics in my clinical practice. And we're going to talk to you today about opioid minimizing, multimodal pain management, and really a discussion of the latest data, techniques, and trends for opioid sparing surgery, what I believe is a super important. So they're on our radar. What does this mean? Well, back 20 years ago, if I didn't write a lot of pain prescription medication for my patients, I could be turned into the board of registration for neglect. So we were told we have to use opioids. They're inexpensive. They're non-addictive. We're going to get our patients out of pain. We're going to grade you for it. Pain's going to become a vital sign. And the entire society of medicine was focused on maintaining patients' pain. And really it allowed us to really get out of control. And we helped to create this crazy opioid crisis that's available at this point. The U.S. Attorney in Massachusetts basically sent out a letter to the top 40 prescribing opioid doctors in the state, telling them that you've been identified as a source of concern, and this is a serious warning. So if you go and take that one step further, this is a doctor in my local community who was indicted for involuntary manslaughter because his prescriptions were associated with a patient that went on to an opioid overdose. So it is super serious at this point. Doctors need to change their patterns of behavior, and we're really trying to change the paradigm of post-operative pain management. This is literally what you want for your kid who is 18 years old to undergo ACL surgery. He's in the recovery room. He's had a quadricep tendon autograft ACL reconstruction, which, as we all know, is typically a painful operation. He is completely pain-free, sipping away on his drink, ready to rock and roll home and text everybody that he knows how well the surgery went. And really, this is the reality. We can actually do opioid-free ACL surgery at this time. These are the patients, if you all recall, were very vulnerable to opioids. There's story after story of kids there at this age undergoing ACL surgery that become addicted to narcotics and then actually die of overdoses. So this is a really a major accomplishment that we're really very proud about. Now, a sort of another clinical example here, but this is a gentleman who's approximately 12 days out from his total knee replacement. We're using a few things for him. We use this device called iovera, which is a cryoaxonomesis device. Liquid nitrous oxide freezes the nerves around the knee for upwards of 3 months. So they don't get that super painful response in the setting of rehab to try and get improved range of motion. We then numb them up with liposomal bupivacaine at the time of the surgery. And here he is, no assisted devices, wearing flip-flops, not so crazy about that can independently walk. And this is just a great example of how we're really minimizing the exposure of opioids to our patients for what are really very highly painful operations in the past. So let's talk about the inexpensive nature of opioids, right? There's no major cost associated with it. They're inexpensive to use. Opioid alternatives are more expensive, but we're going to keep using the opioids. Well, you can see the mortality, lost productivity. It's billions and billions of dollars, government assistance, excess health care, crazy cost to our society, much less the loss of life associated with this opioid. Again, if you take a look at Massachusetts, these are specific numbers for 2017. Really, $6 billion lost productivity, hundreds of millions of dollars for emergency room visits, the cost to communities for maintaining our police force and our EMT services with Narcan for opioid addiction and overdoses, absenteeism from work. I mean, the list goes on and on and on as to how much and how expensive the epidemic is. And really what's happened, and that's the part that really for me is most concerning, is that the operating room itself became a gateway to the opioid epidemic. Not because we were bad people, not because we were trying to get people addicted. I'll be the first to admit, I was part of the process. I mean, we were all told this, and I'd just like to say that we were all sort of schnookered into believing that there was this pain crisis that we needed to manage and maintain, and ultimately speaking, we were actually contributing to it, actually not helping. This is a super important slide, and I'm going to call out 3 numbers, and this is the most important slide I want you to think of today when we're all done. I'm going to give you out 3 numbers, 6, 13, and 30. If you give a patient, 100 patients, a prescription for a narcotic for only 24 hours, It's hard to believe, but 6 out of 100 patients will still be on opioids at 1 year. If you give them a 10-day supply to 100 patients, 13 out of 100 will still be on opioids at 1 year. If you give them a 1 month supply, literally 30 patients out of 100 are still on opioids. These are incredibly addictive medications. We need to minimize exposure. Listen, I'm not completely anti-opioid. There are patients that are on chronic opioids. I understand that, cancer patients, etc. But what we really need to focus on is that patients that are opioid naive should never be started on opioids as a first-line treatment for chronic conditions, and we need to minimize their exposure at all costs in the as well. So you can see the impact of opioids on surgical patients. We all help to contribute. Orthopedic surgeons are the third largest prescriber of opioids in 2016. 4 out of 5 new heroin users started on prescriptive painkillers. They may not end up on painkillers that are prescribed, but that's where they started. These are well-established facts at this point. So again, it's all hands on deck to come up with a solution how we can do this differently. You can see here the percent of newly persistent opioid patients. These are all operations that you guys are all very familiar with. Rotator cuff surgery, literally 10 patients out of 100 are still on opioids well after their surgical intervention. And that's because it has been a very painful operation. The good news is not so much anymore. We're now doing opioid-free rotator cuff surgery with excellent result. Same thing for hips and knees here as well. So the economic impact on our healthcare system, we need to come up with solutions. And so we come up with ideas of how can we minimize the opioids to try and provide safety, reduce the adverse drug events associated with opioid use. Opioid-related deaths are one of our nation's preventable public health problems. If we do this without opioids, can we get them up and running faster? Can we reduce costs to the system? I think all of those answers are yes. And can we start to minimize the economic burden on the healthcare system as well as society? So here, let's take a look at opioid abuse and dependency with a negative impact on worker productivity. So basically, patients with opioid use disorder have tremendously increased number of missed work days, had higher job turnover as well. And so really, as a general rule, creating a problem within our workforce as well. Percentage of workers' comp claims always include opioids, unfortunately, and a lot of these patients are on greater than 90 days. They're not going to return to work. They're going to be chronically addicted to these medications, and basically 4 times higher for patients. Total workers' comp claim costs 4 times higher for patients that are prescribed opioids versus not. Tremendous cost to the system is the message here, loud and clear. So in the midst of our opioid epidemic, the U.S. healthcare system is doing a lot to try and transform. We're going to an outpatient model. We have bundled payment systems. We've developed what's called ERAS protocols, which are enhanced recovery after surgery. All of these things are done to improve quality, outcomes, cost control by basically reducing the need for opioids and then all of the downstream effects that are associated with that as well. So we can make a difference, and we are. That's the good news at this point. So everyone agrees that for a change, the CDC, AOS, all of the major societies have all been on board at this point to be opioid minimization is a good thing. Remember, patients have indicated at this point that they'd rather deal with their own pain without the risk of addiction as well. So the message is loud and clear now to patients. They want options that are available for them that are not using well. There's lots of ways in which that's occurring for the patients. Plan Against Pain, which I'm a part of, as well as the Choices Matter campaign. All of these things and all of these societies here as well are pushing towards change to empower patients, to let them know that they have a choice, that you can seek out doctors who are going to go through your surgical intervention by opioids as well. So what are we doing to create? We use a multimodal approach, first of all, as we all are aware. There's medications that work locally at the tissues. There's medications that can be taken by mouth. And then there's also regional medications that can also use for nerve blocks, anesthetic, etc. All of these things can be used together in a combined multimodal approach, which will then minimize the exposure to opioids. The issue has always been that opioid alternatives are more expensive typically than their alternative, but I guess the point that I try to drive home routinely is they may be more expensive on the front side, but will save us tremendous amount of healthcare dollars and lives on the backside of it. So what's the typical opioid-sparing multimodal therapy approach? We're going to preoperatively use medications. At this point right now, I'm actually using IV meloxicam as well as IV Tylenol. We've eliminated opioids at all completely from our preoperative standpoint. Intraoperatively, we're using longer-acting anesthetics as well, which provide for pain relief. In addition, preoperatively, I mentioned it, we're using a device called iovera, which is this freeze ray gun is what I like to describe. Basically, it freezes the nerves for up to 3 months. We're not ablating nerves, we're not killing nerves, but just taking the anterior femoral cutaneous nerve and the infrapatellar branch of the saphenous nerve and putting them to sleep for 3 months really helps in their post-operative management. And then post-operatively, we actually write prescriptions, and I'll tell you the prescriptions I write because I think it's very specific and very important. The first prescription that we write is for Tylenol. Most patients think that, oh, well, Tylenol is just an over-the-counter thing, it's a voluntary thing, but it really isn't. Tylenol is a great pain reliever. We write a prescription for Tylenol, extra strength, 500 milligrams, 2 tablets every 8 hours for a total of 5 days, letting and emphasizing to the patient know that Tylenol actually helps and we encourage them to use it. Number 2, we actually write for gabapentin, 300 milligrams at night. We only use it at night. Does help with pain, also helps with sleep as well. Again, only for 5 days. There's been some negative talk about gabapentin, but I think in a short burst of 5 days is quite reasonable. I talked about how we use IV meloxicam. Preoperatively, we're using meloxicam. Postoperatively, 15 milligrams once a day, again for 5 days. The reason we use meloxicam is a COX-2 inhibitor, reduced associated complications associated with nonsteroidals, and it's also does not require pre-authorization for most. The intra window in which we have really created a major difference is with the use of a long-lasting non-narcotic local analgesic, and that's liposomal bupivacaine. Basically, it's a standard anesthetic that we've had previously, and it gets put inside this liposome, which is like a fat containing circle that allows for the bupivacaine to be released over time. It helps with opioid minimization. It's broad and indicated use for both soft tissue and bone operations. It's not indicated for a specific operation. Has long duration of effect as well. So really major plus and a major breakthrough in the treatment of our patients. So liposomal bupivacaine in the Depafoam, you can see here, which is the liposomal product. It basically allows this to sort of break down, the fat breaks down over time, thereby releasing the medication so you can get pain relief outwards of 3 days or so. Without boring everybody too much, here's the pharmacokinetics. You can see there's a little blip that happens because there's a little bit of free bupivacaine within the system itself. And then there's a second activated peak, which happens at about 36 hours and can go all the way out 72 to 96 hours. What's great is that with this medication in particular, while it's in the liposome, it's technically not in the body. You don't have to worry about toxicity associated with Marcaine or bupivacaine typically. There's really no major issues with regards to cardiac or CNS effects, as it never really reaches high levels within the tissue. The trick about the use of liposomal bupivacaine is that people are worried because we actually admix it with saline, and we also put in some additional Marcaine as well, and we get this cocktail. Can be anywhere from 60 cc's all the way up to 120 cc's. And most people think about, well, if you're putting saline in, you're going to dilute the medication or dilute its strength, but that's not the case at all because of the fact that it's within the liposome. Basically, you're helping to just spread the medication. The way I like to describe it is that these liposomes don't have, GPS or cell phones. They don't know where to go. You have to make sure you put them everywhere in which there's been an injury at the time of the surgery. So any place where there's been an incision, where there's a nerve, you want to make sure that those liposomes get there. And so that's what we do by spreading it out. So we add saline, we add a little bit of regular Marcaine because it can take a little time for this to work, and then we get a volume, and we then make sure that volume gets spread the tissues as well. The newest indication, which has really been the most profound for upper extremity surgery, is now that liposomal bupivacaine is now approved on-label use for interscalene brachial plexus nerve blocks, which means instead of having a Marcaine block that wears off at about 12 to 20 hours, which is the worst possible time, these patients are getting typical motor block for 24 hours, sensory block for 36, and pain relief potentially all the way out to 5 days. So the most painful surgeries, total shoulder replacements, rotator cuff repair, shoulder instability, all of those operations, ORIFs, can now literally be done near opioid free because of the fact that we're using this. So there's no need for pumps or catheters. Significant improvement. So as far as the level 1 phase 3 randomized controlled trial, it was done against a placebo effect. Bottom line was, you can see here again, motor function 24, 36 sensory, and pain relief well out into the 2 to 3 day range as well. Most of the patients in my clinical practice that have received this block do not require any narcotic in the postoperative window. So it has been a profound change in how we are treating our patients as well, which even allows for any of the physical therapists out there that are treating my patients that know me, we allow for early range of motion and movement because these patients are in less pain. So we're really seeing reduced frozen shoulders and really more rapid recovery patients, especially with rotator cuff repairs as well. Again, I won't get into the depths of this, but the bottom line is that it's done as an ultrasound guided block, which is typically performed by the anesthesiologist. Make sure it gets into the right position and place. So, I'm not going to go in and play this video here, but this is one of my PACU nurses, and I'll never forget it. We started using these blocks April 18th, I think, of 2018. She comes up and finds me like 2 weeks after we started. She's like, Doc, I want to talk to you. And I'm like, oh God, here we go. There's problems. People aren't happy. She's like, it's the craziest thing. I'm calling your patients the day after surgery and they're picking up the phone. And I'm like, why? That doesn't seem crazy to me. That's a good thing. She's like, no, you don't understand. With a standard Marcaine block, they would have the worst pain the next morning. They'd wake up, they're throwing up, they can't talk, they couldn't sleep at night, they have terrible pain. It was always the family member I had to talk to. But now, with this way we're doing with the blocks, the patient picks up the phone, they're reading the paper, and they're drinking a cup of coffee. She's like, it's unbelievable how remarkably different it is. And I think that's really the take-home message here. I like to describe all surgical intervention as sort of like the storm of pain. The storm of pain happens within the first 3 days of the surgical incision, right? If you think about it, it hurts really badly if somebody would take a knife to your skin and you were awake. But 3 days later, the wound's healing, is not hurting so much anymore. And the same thing happens at the surgical intervention. So we try to provide them a soft landing. And that's what this block does by providing them significant pain relief over time. So within the literature, if you take a look at liposomal bupivacaine, some of the time it can be either confounding or be consensus. And I like liposomal bupivacaine is sort of like the Grateful Dead or black licorice. You either love it or you hate it. There's no in between. And so oftentimes we're seeing variations within studies. The question is, why is that? Evidence-based learning is required. Is technique critical, which it definitely is. And how can certain journals be publishing one thing and another journal another? So, here's, for example, is a shoulder example. So this is a study that was done by Paul Sethi, who's an orthopedic surgeon down in Connecticut. It was published in the Journal of Shoulder and Elbow Surgery, one of our country's top leading journals. It was a randomized controlled trial looking at arthroscopic rotator cuff repair. They basically did ultrasound-guided interscaling block with bupivacaine because it was not on label yet. And then they took a look and also did a block using liposomal bupivacaine basically into the soft tissues. So they did a nerve block for the arm and then did a localized injection of liposomal bupivacaine all around the area. And at the end of the day, these patients had significant reduction in opioids and pain relief. And this was what was published, it was documented, and life is good. Then we go, and now we have another paper published by Namdari, who's also an excellent orthopedic surgeon, published in JBJS. They also did a randomized controlled trial for total shoulder replacement. There was no multimodal pain management. They allowed the patients to have a PCA. They did an ultrasound-guided block with ropivacaine, which is similar to bupivacaine, and then they basically did the same sort of local infiltration with the liposomal bupivacaine. Basically, they showed that the patients that had the liposomal bupivacaine has higher opioid use and no difference in pain. I find, so it's amazing to me that two respected orthopedic surgeons in two respected journals do a similar study and come out with completely different results. In my experience, it really comes down to technique with the use of liposomal bupivacaine. You have to have the right volume. You have to get it to the right places. And that's the pivotal reason that that these studies either fail or they don't. And I would argue that the technique used in this JBJS article was substandard, and that's why the results were poor. So here's another one. Let's go back to the knee now. Let's talk about total knee replacement. Retrospective cohort study. They basically took a look. They did this technique, which is ropivacaine and a bunch of other medications mixed together, and they do a local block all around versus the use of liposomal bupivacaine in a block as well. So here they used a total of 50 cc's of volume for the liposomal bupivacaine. And we clearly know you need 120 cc's in order to get an adequate result because you got to put it in all the right places. So yeah, they got a poor result. No statistical difference in the first 24 hours. And it's not surprising. It's not because of the fact that liposomal bupivacaine works. It's just that it has to be used correctly. And so you have to make sure you read to really understand them if you're trying to make a difference. And then here's the classic study, which was done by Michael Mont, a prospective randomized double-blinded multi-center trial. Basically, the control was the use of just using bupivacaine versus the technique of using liposomal bupivacaine, and there was drastic differences in the results. It's called the Pillar study. I'm going to run through it really quickly. In the Journal of Arthroplasty. The most important thing, again, is making sure you've got the right infiltration technique and protocol, the right amount. And at the end of the day, happens, you can see here 120 cc's is what we recommend, and then you put it in all the right places. In addition, it was part of a multimodal pain management protocol that you can see here as well. So done, this is a study. This is the technique and how you put it in. You make sure you get it to all the right places. Any of the bone cuts, any of the soft tissue cuts, all need to have the injection of the material, so that way all the nerves that have been injured are going to be covered. And so you can see here that there was an 80% reduction in the use of opioids with the liposomal bupivacaine versus standard marcaine. So let's just put this to bed. Let me be very clear. Liposomal bupivacaine works. If you use it in the correct way with the correct technique, you will get a good result. Your patients will therefore require opioids. Through this here. So the key takeaways though from the pillar: make sure you got the right volume, make sure you're putting it in the right place, make sure you're using this in a multimodal pain management protocol, make sure the surgeons are trained appropriately. All of this comes. So basically, it all started within, the inpatient setting. So I can recall back to 2014 or 2013 when I first started using the material. We were using it in the hospital, specifically for total knee replacements, and the nurses were blown away at how well the patients were doing. Everybody knew who the Sigmund patients were because they were up and moving around compared to my other colleagues. Now we have them all doing it as well, which is great news. Early on, it took a while for everybody to drink the Kool-Aid, but it was then my thought, well, why are we just doing it on the inpatient? Can we develop these protocols to the outpatient setting? And that's what we've done. And so we developed surgeon advisory boards, and we study the neuroanatomy of the individual places in which we're operating. We identify the nerves that are a part of the process. We can then do some regional nerve blocks around, and then we can also do the local anesthetic locally. And for all of these surgeries, we can eventually develop a care plan, which is very easy for surgeons to learn. All these videos are available online. You can become an opioid-sparing orthopedic surgeon tomorrow if you wanted to. The techniques are not cumbersome or difficult as well. So I was involved in the creation of an ACL protocol for quadricep tendon autograft ACL, but also as well as patellar tendon. Again, we all put this into perspective now. We give cookie cutter instructions. This is the volume that you need. 20 of Exparel, 20 of liposomal bupivacaine, 20 of standard bupivacaine, 0.25%, and then normal saline. You get 80 cc's, and then march out, and you get all of the areas that are involved. So we do the incisions as well. I think that you can see over in this area in here, but we get the incisions, but we also get the regional nerves. We get the anterior femoral cutaneous nerve, and we also get the infrapatellar branch of the saphenous nerve, and then we basically get every other area that's going to be involved in the surgical intervention. Now, we talked about the fact that we have the new on-label use of liposomal bupivacaine for these upper extremity surgeries, but if it's a patient that has COPD or you're worried about the phrenic nerve and you don't want to do a nerve, you can also do local infiltration as well. And for this, we will typically use liposomal bupivacaine with saline up to 60 cc's. Develop this triangle. The triangle is important because it gets the suprascapular nerve, it gets the axillary nerve, all of which have sensory fibers, and then you get the local incision sites as well. And this allows for local infiltration with 60 as well. Same for total shoulder replacement. Again, 20 of liposomal bupivacaine, 20 of the 0.25% bupivacaine, and 40 of saline. You can then make sure it gets to all of the soft tissues and areas that have been injured with the surgery. Knee, that's 120. Again, getting to all to make sure you get a good You can certainly do it for anterior total hip replacement protocols as well. You can see here's the infiltration. You can do it. Here's my dear friend Nirav Amin out in California has done a study. At this point, he's using liposomal bupivacaine with this amount of 100, localizing to all the sites in which with the surgical intervention is happening. And these elderly patients, which are some of the ones that are most at risk for disease process, are literally able to undergo major hip fracture surgery without opioids, which is really quite remarkable. Time protocol at this time as well. As you can see here, the message that we're trying to get at is that we have developed techniques that can be used for these local infiltration so that most of our patients now that are undergoing intervention for surgery can be brought into an opioid minimization protocol. So in conclusion, a multimodal pain management protocol can help to reduce opioids. Liposomal bupivacaine is a key part of that success story for me in clinical practice, and when it's used correctly, it can optimize the outcome of the patient. So end it there. It's been a pleasure. Thank you so much for the opportunity to be able to share what I think is really one of the most important things that we're doing in clinical practice at this time, and that is changing the paradigm of postoperative pain management. Thank you so much.